told you that for some people with rheumatoid arthritis, it might be possible to stop taking those powerful medications. You know, the ones with all those side effects and regular blood tests? Sounds too good to be true, right? Well, today we're diving into what the science actually says about discontinuing DMARDs when your disease is under control. Stay with me to the end because the answer might surprise you and could potentially change the conversation you have with your rheumatologist at your next appointment. Before we dive in, let's make sure we're all on the same page about what DMARDs actually are. DMARDs stands for disease-modifying anti-rheumatic drugs. Unlike pain relievers that just mask symptoms, these medications actually slow or stop the progression of rheumatoid arthritis by targeting the immune system that's mistakenly attacking your joints. They come in two main categories: conventional DMARDs like methotrexate, hydroxychloroquine, and leflunomide, as well as biologic DMARDs like adalimumab, etanercept, and rituximab, as well as targeted synthetic DMARDs like Xeljanz or Rinvoq. While these medications have revolutionized rheumatoid arthritis treatment, they come with significant downsides. Many require regular blood tests to monitor for side effects. They can increase your risk of infection, and some might have to be injected or, even worse, infused. And let's not forget the financial burden. Biologics, in particular, can cost thousands of dollars per month without insurance coverage, and even sometimes with insurance coverage. So it's no wonder that many people ask themselves, do I really need to be taking this medication? Can I stop my medications? That's exactly what we're going to explore today. Using the latest evidence-based research, I've combed through dozens of studies from PubMed to bring to you the most current and whether it's safe to discontinue DMARDs, what the best practices are, and when it may not be so appropriate. Let's talk about what it means to have rheumatoid arthritis under control. Rheumatologists use specific terms like remission and low disease activity, or LDA. These aren't just subjective feelings and what we kind of think is going on, but they're actually defined by specific measurements. The most common is the Disease Activity Score 28, or DAS-28, which combines joint count, lab values, and patient assessments. A DAS-28 score below 2.6 is considered in remission, while a score between 2.6 and 3.2 indicates low disease activity. Other measurement tools include the Simplified Disease Activity Scale, or Index, called the SDAI, or the Clinical Disease Activity Index, or CDAI. This is what I actually use in my practice. It's important to understand that there is difference between true remission and drug-induced remission. True remission would mean that the disease has naturally gone into hibernation, while drug-induced remission means that the medications are successfully suppressing the disease. The challenge that we face is that it's difficult to know which type of remission a person has without attempting to reduce or stop the medication. The good news is that the remission is now an achievable goal for many people, especially with early aggressive therapy. This wasn't always the case. Before modern DMARDs, rheumatoid arthritis often led to severe joint deformities and disability. Today, with the right treatment approach, many people can lead normal, active lives with minimal symptoms. So what does the research actually tell us about stopping DMARDs once remission or low disease activity is achieved? A 2023 systematic review by Ward and colleagues looked at this exact question, focusing specifically on tumor necrosis factor inhibitors, a common type of biologic DMARD. They found that approximately 50% of people with rheumatoid arthritis remain in remission or low disease activity for up to 1 year after discontinuing their medications. That's a significant number. Half of patients maintain their good disease control even after stopping these medications. The researchers distinguished between two different scenarios: induction withdrawal studies, where patients achieved quick remission with TNF inhibitors and then discontinued the medication. And the second scenario was maintenance treatment discontinuation studies, where patients had been on long-term TNF inhibitors before stopping their medications. Interestingly, the success rates were slightly higher in the induction withdrawal group. At 37 and 52 weeks after TNF inhibition discontinuation, 58% of patients in the induction studies maintain a DAS28 score below 3.2, compared to 48% in maintenance studies. So what were factors that predict successful discontinuation? The most consistent finding across these studies was that longer disease duration was associated with less successful discontinuation. In other words, people who had rheumatoid arthritis for a shorter time before achieving remission were more likely to maintain that remission after stopping DMARDs. This supports the concept of the window of opportunity. So early in the disease, when aggressive therapy or treatment can potentially lead to long-term benefits. Other factors that might predict successful discontinuation include deeper remission before stopping, shorter duration of symptoms before the diagnosis, and the absence of anti-CCP antibodies. This is a blood marker associated with, which typically is associated with more severe disease. These findings were not as consistent across the studies. Now let's talk about safety concerns. The primary risk of discontinuing DMARDs is, of course, disease flare. When this happens, most patients will respond to restarting the same medication, but there's no guarantee. A 2011 review by Chimenti and colleagues noted that when anti-TNF inhibitor therapy is withdrawn, the disease often rapidly returns. This highlights the importance of close monitoring after discontinuation. Another concern is that even without noticeable symptoms, there could be ongoing joint damage. Some studies have used ultrasound or MRI to detect subclinical inflammation in patients who appear to be in clinical remission. This silent progression could lead to long-term joint damage even when a patient feels fine. That's why imaging studies may play an important role in monitoring after DMARD discontinuation. So what are the best practices for discontinuation? Based on the current evidence, here are a few guidelines. Patient selection is critical. The best candidates for DMARD discontinuation are those who have achieved sustained remission, so typically at least 6 to 12 months, and have had relatively short disease duration, respond quickly to treatment, and don't have factors associated with aggressive disease like high levels of rheumatoid factor or anti-CCP antibodies. A gradual tapering approach is generally preferred over abrupt discontinuation. This might involve reducing the dose or increasing the interval between doses before stopping completely. For patients on multiple DMARDs, it's usually recommended to discontinue one drug at a time, often starting with the biologic agent while maintaining the conventional DMARD, such as methotrexate. Third, close monitoring is essential. This typically includes more frequent rheumatology visits, regular disease activity assessments, and possibly imaging studies like ultrasound to detect early signs of inflammation. Patients should be educated about potential flare symptoms and instructed to contact their healthcare provider promptly if this happens. Shared decision making is crucial. The decision to discontinue DMARDs should involve a thorough discussion between the patient and the rheumatologist, weighing the potential benefits like reduced side effects, lower costs, fewer medications, against the risks, disease flare, joint damage. But discontinuation isn't appropriate for everyone. Patients with long-standing disease, a history of aggressive disease or rapid radiographic progression, or previous failed attempts at discontinuation may not be good candidates. Those with high-risk occupations where a flare could significantly impact function, or comorbidities that might exacerbate or be exacerbated by RA flares may also be better off continuing their treatment. And of course, patient preference plays a role. Some people may prefer the security of continued treatment over the uncertainty of discontinuation. It's worth noting that there are still significant gaps in our knowledge. Most studies on DMARD discontinuation have relatively short follow-up periods, typically 1 year or less. We have limited data on long-term outcomes, including the impact on joint damage and disability. There's also the need for better predictive biomarkers to identify which people are more likely to maintain remission after discontinuation. Several ongoing trials are addressing these questions. For example, researchers are investigating whether ultrasound-detected synovitis can predict flares after DMARD tapering and whether certain blood biomarkers might serve as early warning signs of disease reactivation. The field is also moving toward more standardized protocols for DMARD discontinuation. Currently, there's considerable variability in how rheumatologists approach this, but organizations like the European League Against Rheumatism, EULAR, and the American College of Rheumatology are working to develop evidence-based guidelines. So what does this all mean for clinical practice? The evidence suggests that DMARD discontinuation is possible for approximately half of patients who achieve remission or low disease activity, particularly those with early disease who respond quickly to treatment. However, this approach requires careful patient selection, gradual tapering, close monitoring, and readiness to restart treatment if needed. The implications for patients are significant. For those who successfully discontinue DMARDs, the benefits include reduction in medication burden, fewer side effects, lower costs, and potentially improved quality of life. However, these benefits must be balanced against the risk of disease flare and possible joint damage. So here's the bottom line. Yes, for some people with rheumatoid arthritis who've achieved remission or low disease activity, especially those who respond quickly to treatment in early disease, discontinuing DMARDs might be possible, but this isn't a decision to make on your own. The research shows us that careful selection, gradual tapering, and close monitoring are essential. The most important takeaway is that treatment decisions should be individualized. What works for one person may not work for the other. Armed with this knowledge, you can now have a more informed conversation with your rheumatologist about whether DMARD discontinuation might be an option for you, because ultimately the goal isn't just controlling your disease. It's giving you the best possible quality of life with the least medication burden necessary. Remember, rheumatoid arthritis treatment is not a one-size-fits-all. The journey is different for everyone, and what matters most is finding the approach that works best for you. I hope this information helps you navigate that journey with greater confidence and knowledge. Thank you for watching, and if you found this information helpful, please like and subscribe for more evidence-based health content, and don't forget to check the description below for the references to all these studies that were mentioned in this video. I'll see you in the next one.